Apart from the most perplexing situations in endodontics, there should be basic steps that we have to follow before we start the endodontic treatment.
So I guess we are now going to discuss about endodontic diagnostic procedures. Ladies and gentlemen, welcome to episode number 16 from Endocast, hosted by Francesca Cerutti. Hi, Francesca.
And by Ahmed Shawky. Hi, Ahmed. So, today we are going to go through the steps and workflow during the diagnostic phase of the endodontic treatment. And we need to emphasize that this step is the foundation for a proper endodontic treatment because we need the correct diagnosis before doing all the following steps. And this is going to guide the clinician to a proper treatment planning, so priority sorting, and also to outcome prediction.
And as many of our colleagues already know, the proper diagnostic workflow should integrate sound subjective, which mean patient part and patient-centered findings, and objective findings, which are clinical-based assessments, and of course radiographic findings to reach a proper clinical decision. So it is important to obtain the verbal statement from the patient as an initial step in your diagnostic procedure. It will help you a lot in your diagnosis. So my suggestion is to never interrupt the patient and let him or her speak freely because this will help you a lot.
Yeah, I definitely agree. And after this, the first step in the workflow is the clinical examination. But remember that we are treating patient, not just teeth, and so clinical examination starts from outside mouth. So we start from an extraoral examination and then we go through the intraoral to examine specific areas, and in general we ask to the patient where is the area in which you have pain, and it shows us, so it's easier for us. But don't forget that it's not only the tooth. We have to examine also the surrounding tissues, soft tissues, to see areas of swelling, redness, sinus tracts, etc.
Exactly. And don't be shy to use your fingers because it is always necessary to do a bi-digital palpation and detection of the area so that you can detect areas of abnormality or tenderness in relation to a specific offending tooth and compare it to the other normal side in the patient mouth.
Exactly. In addition, the mobility assessment is very important together with the periodontal examination through probing to determine the periodontal status and might give us an indication about, for example, an endoperioral lesion or a vertical root fracture, which is a topic that I think needs to be discussed separately.
I agree about that, and we will definitely have time to discuss that. An important assessment during the diagnostic workflow is the sensibility testing. And let me say that it's not sensitivity, it's sensibility because we detect the deviation from the normal sensation of the tooth so that to detect what is abnormal in our case. And we go with a sensibility testing, which can assess the tooth vitality indirectly through a thermal test like a cold or hot test, and also with electric pulp testing.
And we have to be frank, the most accurate test to determine the pulp vitality is laser Doppler flowmetry, but we don't have that kind of device in our practice. We rely on the cold test, okay, which you can choose to do with an ice stick or as I do with the endo ice on cotton, and then you put the cotton on the tooth. And this can assess the vitality based on the response of that particular tooth in comparison to the adjacent and contralateral sound teeth. And in general, you never start from the tooth you think has a problem. You start from a sound tooth, and then you say to the patient, okay, this is what a normal tooth feels like, and then you slowly approach to the area of interest.
And to be honest, because the most reliable test is the cold test, and the hot test is less reliable than the cold test, but we do not omit it from our diagnostic workflow because it can help us to just confirm some findings, and also it can help us to detect some inflammatory conditions or advanced inflammation of the pulp, like the hot teeth, because it can stimulate a C fiber response deep inside the pulp due to expansion of some of the inflammatory exudate in the advanced pulp inflammation.
Exactly. And then we have another method of pulp sensibility testing, which is the electric pulp testing, which aims to assess of the neutral element in comparison to normal sound teeth. However, it can yield to a false positive result, as in case of metallic restorations, for example, or liquefactive necrosis of the pulp, and may also yield to false negative response in case of advanced calcification or young permanent teeth or after traumatic dental injuries. So we have to be careful while we interpret the results of this test.
And we need to highlight that when we're talking about the diagnostic test or the clinical examination, that no single test is enough. It's never enough. And we have to combine all the data that we collected from all the tests, because that will help us in the reliability of the decision that we take to treat a specific case. And the next step is to do a gentle tapping along the long axis of the tooth to assess involvement of the periapical tissues. For example, in cases of symptomatic apical periodontitis or an acute apical abscess, all those inflammatory conditions involving the periapical and periodontal tissues. This is, of course, the percussion test. And to be honest, sometimes we do it first using our fingers. If the patient, especially if the patient is coming complaining of severe pain on biting and he cannot just bite on the tooth, or feeling of a tooth elongation, as we call it, so we just not taking the mirror and hit him with the back of the mirror. So first I try with my fingers. This is more gentle than do it with a metallic object in the first instance.
And then we still don't have to be afraid of using our fingers, because we have to do some palpation and then periodontal probing. The palpation test will help us detecting advanced apical periodontitis, while probing can differentiate between, for example, an endoperiodontal lesion and vertical root fracture. And this is very important, because sometimes we have to take a decision whether to treat the tooth or not, and to understand if extraction is the best option or we can go with an endodontic treatment. It's very important.
Exactly, because at the end, sometimes we cannot save all the teeth or treat all the teeth, so we have to know not to waste our time or the patient's time. And after all these steps, which are not too much, by the way, we are coming to the imaging phase. And according to the recommendation of the American Association of Endodontists and the European Society of Endodontology about the first step in imaging, it would be the intraoral digital radiographs. This is the first step. So the two-dimensional radiography is the modality, the imaging modality for the endodontic treatments, which will be the first step to assess the tooth for a restorative point of view. From a restorative point of view, highlight the periapical tissue status or involvement, and is better performed using a paralleling technique in order to maintain the dimension of the tooth and be able to evaluate all those factors.
Yeah, Ahmed, I do completely agree. But sometimes a bidimensional X-ray is not enough, because we might need to clarify certain situations like resorption, perforation, missed canals, or the effect of cracks in the adjacent bone. And here comes the role of the CBCT, especially in complex cases or in retreatment cases. But we have already seen it in the last episodes, so we are not going into much detail. And whatever the imaging modality indicated for the case, we have to detect areas of radiolucency or radiopacity, and we have to evaluate the symmetry and integrity of the lamina dura all around the roots, as well as the morphology of the root, which is going to give us highlights about the most likely internal anatomy even before starting the treatment. So we have to be prepared.
Exactly, and when you are prepared, you are not going to do errors, and the treatment will be smooth, of course. And it's not always the case in our cases, of course. So now we come to the diagnostic terminology, because after that you have to sort out which condition you are treating. And for a long time we have used the classic or the traditional diagnostic terminology, such as reversible or irreversible, sometimes symptomatic or asymptomatic, sometimes we say acute or chronic. But in the past 4 to 6 years, there have been some updates about such terminologies. And I guess we need to know what are those updates, Francesca?
Yeah, I found very interesting to read this article because, of course, endodontics evolved through the years, and there are some new procedures that we perform that we didn't use to perform in the past, like regenerative endodontics, or we might start an endodontic treatment on a previously initiated tooth. And so this article just wanted to find out the concordance between endodontic specialists about diagnosis on different cases and the terminology that they used, and finds out that, of course, we don't agree 100% of the times, but this is kind of normal, and also that sometimes we have not the terms to define a pathology if we just stick to the old classification. And so they try to introduce new terminology like non-responsive regenerative pulp, when we have a pulp treated with regenerative procedure that is not responding to sensibility test, or responsive regenerative pulp when the pulp was treated with regenerative procedure but still is normally responding to the sensibility test. And then we have also some inconclusive pulp conditions. The typical case in which you just wait and see what happens because the pulp is asymptomatic but is not responding to test, but also there are no signs of pathology in the x-rays. And so you are in that condition in which you say to treat or not to treat. Well, Latin said primum non nocere. So first of all, if there is no symptoms and no radiographic evidence of a pathology, we don't do anything. We just wait and see what happens. And then we have also an inconclusive periradicular condition where there are signs of inflammation in the x-ray, but still the pulp is vital according to our sensibility test and there are no symptoms. So these are cases in which we just wait and see, because seriously there is no indication for root canal treatment in these cases. And then the article tried to define the terms normal pulp, reversible pulpitis, etc., in order to give clarity, because most of the times we have to communicate with patients, but sometimes we have to also communicate with colleagues, and when we communicate with a colleague for a referred patient, for example, we need to write down our diagnosis and we should use the appropriate terms, in my opinion. What do you think, Ahmed?
Yes, I totally agree, because in our practice, especially as endodontists, we need to communicate, as you said, with our colleagues, and maybe we can diagnose, we can do a consultation for some patient, and we need to just know how to communicate together. And I totally follow all the updates. when they are out, and I recommend always to all my colleagues to follow such updates, because these updates in terminology aims at correlating also the clinical signs with the treatment planning and of course the outcomes. This is very important part of the terminology when it is out, or a new terminology to come out, that it can correlate our clinical signs and symptoms with the treatment planning or the treatment option indicated for that tooth. And it can be seen in the new terminology that was out in 2017 by Walters et al. In the International Endodontic Journal. This terminology classified pulpitis into four stages, from mild to severe, and not just a reversible and irreversible pulpitis. And this will help the clinician to treat the inflamed pulp not only by taking it out, but sometimes we can do an indirect treatment. Sometimes we can do just restorative treatment. Sometimes we can do a vital pulp treatment like the partial pulpotomy or complete pulpotomy, or a root canal treatment. So this classification also is a new thing that we need to just incorporate in our diagnostic procedures.
Very, very interesting. And of course, in the end, when we have collected all the data, we have to just analyze them in order to determine what the problem is and in order to formulate a correct treatment planning. But we will definitely go deeper into endodontic diagnosis in the following episodes. But the take home message is really to try to all examine the data you collected and try to find out which is a problem. Because only if you find out which is the problem, you're going to do a correct endodontic treatment.
I totally agree that diagnosis is a multi-step procedure that should be standardized for a proper treatment plan and a patient-centered or a patient-relevant outcome. So, guys, stay tuned because we're gonna go deeper in the next episode about diagnosis. So, stay tuned. Bye.
Ciao!